Welcome to the Infectious Disease Detection and Surveillance, or IDDS project. This webinar is being recorded. Attendees are in listen-only mode. The recording will be available later in the week to all those who've registered for this webinar. Your GoToWebinar interface should look something like this. If you go up to the far right of your screen and click on the little white arrow in a red-orange box, you will open up an interface. You will see that there are controls. There is a handout in a PDF. It's a fact sheet for the IDDS project. You will also be able to click on a little arrow next to questions and open up the question box or interface. That is where attendees can pose their questions, which we will try to address during the question and answer session at the end of this webinar. Attendees, again, are in listen-only mode. And now to our program.
Good morning and good afternoon, everyone. I would like to welcome you all to this webinar given by IDDS. This webinar is going to look at IDDS's particular work around establishing specimen transport and referral systems. As we know, establishing functional laboratories are at all tiers of the health systems in developing countries remains a significant challenge because of limitations such as poor infrastructure, lack of trained human resources, maintaining and establishing good biosafety, and limited funding. USA, through IDDS, has dedicated significant attention to this need and have identified and limited emerging outbreaks by expanding and decentralizing laboratory services through different models of specimen referrals systems. Today, we're happy to welcome you all and our experts from different parts of the world as they share their experiences in implementing specimen referral systems in their countries and the impact of their work on increasing access to rapid and reliable laboratory diagnostic results. We hope that you enjoy this session and participate in the question and answers immediately following this presentation. Thank you.
Thank you so much, Dorothy, for those welcome remarks and for providing context for the topic today. My name is Fran Jean-Louis. I'm the lead diagnostics network advisor for IDDS, and I will be facilitating the webinar today. First, some additional introductions. Here is our lineup of expert speakers and panelists. We have Mrs. Kamiko Nichols, who is an independent consultant and specimen referral expert. We also welcome Mr. A.B. Bill, who is a public health laboratory specialist with over 30 years of experience in public health and clinical diagnostics. A.B. is the country team lead for IDDS in Guinea. We are also privileged to count among our speakers Dr. Xian Nguyen, who holds a PhD in biochemistry and molecular biology. He is the team lead for IDDS in Vietnam. Vietnam will be also represented by Dr. Nguyen Binh Nguyen, a medical doctor specialist in preventive medicine with over 16 years of experience managing public health projects and conducting research in epidemiology of infectious disease. Dr. Nguyen previously served as the country lead for IDDS in Vietnam. We have included the speakers' bio and contact information for you ahead of their sections in the subsequent slides. We will have a Q&A and discussion sessions toward the end of the webinar, and we are looking forward to great discussions with participants from other countries supported by IDDS across sub-Saharan Africa and Southeast Asia, where we are also implementing specimen referral system. We will be led through the webinar today by our excellent facilitator, Nisha Miles, who is the Senior Manager for Global Health Security for IDDS. I will now hand over to Nisha to walk us through opening remarks, the goals of this webinar, and our topics. Thank you.
Thank you, Franz. So first, we'll be providing some key concepts and definitions to orient everyone to what actually comprises a specimen referral system. And we'll review these concepts within the context of global health security. Next, our speakers will share their experiences and accomplishments over the past few years of SRS implementation in their respective countries. And finally, each speaker will present lessons learned based on their experiences of what worked, what didn't work, and we'll conclude the webinar with a lively Q&A discussion. So as our colleagues mentioned before, please feel free to enter your questions and comments in the chat window at any time. Next slide. So first, what is a specimen referral system? Basically, it is a coordinated network of facilities that enables health facilities and laboratories that lack the capacity to perform a test and send that specimen to another lab that does actually have the ability to carry out the requested test. Oftentimes, basic point-of-care tests are available at the lower tiers of the lab network, such as at health centers or through community health workers, with more complex testing capacities available at the regional and central reference lab level. Specimen referral systems can either be decentralized, as seen here in the top left diagram, with results routing back and forth within the tiered structure, or they can be centralized, as shown in the lower right diagram, with a hub and spoke model. The challenge is that centralized testing can be impeded by fragile specimen transport practices, which can then lead to increases in turnaround time. This figure came directly from an article by John Nkengasong and his colleagues in the Journal of Clinical Infectious Disease. The goal of specimen transport is safe and efficient handling and treatment of specimens during the process in order to obtain reliable results in a timely manner. The systems actually enable the required test to be performed and the results to then be returned to clinicians, veterinarians, and other public health officials. Now, ideally, the systems are integrated, meaning that they can transport specimens for multiple diseases like TB and HIV, malaria, and others. And to function optimally, specimen referral systems need to have adequate geographical coverage. They need to maintain specimen integrity, protect the safety of those transporting the specimens, and finally, they need to have sufficient financial resources to ensure sustainability. Kamiko will be speaking about some of these concepts in her presentation shortly. Next slide. So strengthening lab diagnostic networks and surveillance systems is critical in order to ensure public health outcomes, positive public health outcomes. However, there are significant challenges with establishing functional diagnostic capacities at all tiers of the healthcare system, especially in resource-limited countries. SRSs enable labs to serve larger swaths of the population, and they contribute to stronger infectious disease prevention, surveillance, and control strategies. On a larger scale, the systems also empower governments and other decision makers with the information that they need to issue evidence-based policies to contain local outbreaks before they spread. At the onset of the COVID-19 pandemic, specimen referral and transport were definitely at the forefront of every response planning discussion. RT-PCR is the preferred method to confirm COVID-19 cases, but in many resource-challenged countries, this test is usually only performed at the central level. Because of this, many countries were unable to rapidly decentralize testing capacity and were therefore more reliant on the ability to transport specimens from more remote areas to these central labs. However, there are fractured transport systems across many of these countries, which further underscore the need to prioritize strengthening of these systems in order to ensure their resilience. Next slide. To establish a functional specimen referral network, IDDS endeavors to work as closely as possible with government counterparts, key stakeholders, and other implementing partners to identify the highest burden regions of each country and identify any challenges across the specimen referral and transport pathway. We heavily rely on our incredible country teams to identify the best mechanisms to build the referral system on and to identify the regions where we would have the most impact. Then, depending on the needs of each country, IDDS country teams train drivers and specimen collectors on biosafety protocols. We provide essential supplies and reagents and equipment, monitor successes and gaps of the system itself, and then monitor overall impact. As one of the early implementing partners of USAID's emergency response to the COVID-19 outbreak, IDDS provided rapid response to strengthen COVID-19 specimen referral systems in several countries. We applied all of the aforementioned activities to establish these SRSs, but in addition, we focused on designing innovative specimen transport models tailored to the real-time needs on the ground in order to ensure that COVID-19 specimens were properly collected, referred, and shipped to the designated testing facility in each target country. IDDS has demonstrated experience across the entirety of the specimen referral pathway, starting with sample collection. During the initial response, we were also able to pivot our ongoing existing technical assistance efforts towards emergency response while still supporting the core functions of the project. Since the pandemic began, IDDS has also been able to provide ad hoc response and support for many other public health emergencies, including Ebola, plague, and monkeypox. Thank you so much for your attention. I'll now turn back over to our facilitator, Franz, to introduce our first speaker. Next slide.
Thank you, Nisha. And now we will begin with a session led by Kamiko Nichols, an international expert on specimen referral system. We invite Kamiko to share her expertise and experiences on our specimen referral system framework. So please proceed, Kamiko.
Thank you very much, Franz, and thank you to IDDS and USAID for having me in this presentation today. Next slide, please. So I'm going to give a bit of framework to specimen referrals and talk about some guidance that's available. But to start out, to talk about what is a specimen referral system and how does it support both diagnostics and surveillance networks. So a specimen referral system is made up of various components, which you can see on the right side of the screen. There are components such as the transport and logistics, which is one component of the overall system, but there are also other components such as human resources, the finances that are necessary to operate these systems, etc. And specimen referrals then support either the diagnostic networks, support surveillance systems, and again, are one component of these diagnostic networks or surveillance systems. So we can see here the relationship between the two. Next slide, please. And when we think of the goals of a specimen referral system, the overarching goal is that these specimen referral systems should support diagnostics, they should support testing, surveillance systems. And we can break down these goals into 5 different areas. One is around accessibility, and this can be measured by how many facilities are covered by a specimen referral system, or how many referred specimens are being delivered at the testing facility and the volumes that are tested. We can also look at the goal of timeliness, which is usually the goal that is most talked about when we think about specimen referral systems. Timeliness is usually measured by turnaround time. This is the turnaround time between when the specimen is collected and potentially all the way to when the results are returned. Another goal is around quality. So the quality needs to be maintained during transit so that a quality result can be issued. And quality is usually measured by the condition that the specimen received in at the lab. So this is either good condition rate or can be rejection rate. Also, there is a separate goal around safety, around biosafety, around biosecurity. And this is usually maintained and therefore measured by how well the specimen is packaged, and if there are any incidents along the way that might compromise biosafety or biosecurity. And then finally, also importantly, is around cost efficiency. So we can meet all of these other goals, but are we doing it in a cost efficient way? And usually we look at the cost per specimen transported to measure cost efficiency. Next slide, please. Specimen referral systems are always important, but they are increasingly important during outbreak response. And we can really see many examples over the past couple of years where timely and quality results are critical for public health protection. So we could see this, of course, during COVID, during Ebola initially in West Africa and some of the subsequent outbreaks. We're also seeing how important specimen referral is during some of the current polio outbreaks that have been happening in Southern Africa currently and across the world. So it's very important that specimens are referred, as Nisha was mentioning before, to where the more centralized testing is available, and that this happens as quickly as possible and in a quality controlled manner. Ideally, a strong specimen referral system can be used not only for outbreak response, but can be used to support ongoing surveillance so that we are alerted to any potential activities beforehand through surveillance across human, animal, and environmental health sectors. Next slide, please. So when we think about designing a specimen referral system, there are a lot of important factors that should be taken into consideration. One is around how integrated are various disease programs. So is there any multiplexing happening on various platforms? How do the disease programs work together? Or are they very separate? Also, another consideration is where is equipment placed throughout the country? And also how is that equipment placed through the tiered lab network? So that's very important. Also around testing algorithms. So what test happens at what point? There are, of course, quality and biosafety requirements. Physical accessibility is also important. And what type of vehicles or transportation might be available, whether or not there's staff capacity. So all of these factors should be considered when designing a functional and robust specimen referral system. Next slide, please. However, there are many challenges both to the design and the implementation of specimen referral systems. There are challenges around management. So oftentimes in a country, there's not a very comprehensive view and understanding of what specimen referral systems exist in a country. And there is oftentimes very weak coordination, supervision, and communication. On the design piece, some countries do not have access to the tools to properly design an efficient network. Also, what we see, and as Nisha had mentioned, there's fragmented design and implementation. So we often see that the specimen referral systems are siloed, similar to the way that disease programs can be. There's a lot of reliance on outside donors for specimen referral systems, and there's really a lack of understanding of how much specimen referral systems truly costs. And then in terms of implementation, these are complex logistics systems. There are a lot of challenges around implementing. Having the right expertise, having very difficult infrastructure or lack of infrastructure in some countries. Sometimes there's not enough emphasis on biosafety and biosecurity. There might not be packaging that's necessary available in a country. monitoring and evaluation, and anything around data can be a very, very big challenge in most countries. Having the right trained personnel, and then many external factors such as weather, such as security concerns, etc. Next slide, please. But there are a lot of opportunities as well. And a well-designed and functional specimen referral system can really benefit the overall health system. It can help on the patient side by not requiring them to travel to a testing site. And it can really help to ensure that these testing sites where there's been investment in instrument capacity, that those are utilized in an efficient and optimal way. There are also opportunities as countries have been renewing commitments to various international public health policies and initiatives, such as Global Health Security Agenda, IDSR, the International Health Regulations, etc. As countries' specimen referral systems and diagnostic networks mature, there are also opportunities to do optimization. So optimization on the diagnostic network or on the vehicle routes. And this is happening in many countries currently. There's also an opportunity to look at these systems and harmonize them and to take a One Health approach. So to not look even at a specific disease within human health, but to look across human, animal, environmental health and look at harmonizing these systems. And then finally, there's an opportunity to look at private or semi-private sector engagement to involve them within supporting specimen referrals. Next slide, please. And these are just a couple of takeaways for additional resources for anyone who's interested in learning more about specimen referrals. There is a GLI guide. It was specifically developed with a bit of a focus on TB specimen referral systems, but also looks at integrated networks as well. So it's not only focused on TB. Another great resource, and the guide is actually included in this resource, is the Specimen Referral Toolkit. So the link is listed there, and you can find many different resources within that toolkit. Another good resource is the Joint External Evaluation Reports, because within those JEE reports, there is specifically an indicator around specimen referral systems. So you can look at those country-specific reports and then see how a specimen referral system is performing in that country. Next slide, please. And thank you very much.
Thank you, Kamiko, for walking us through the guidance for implementing specimen referral system. And now we are welcoming our next speaker, Mr. Ebi Bill, to walk us through his experiences on implementing specimen referral system in Guinea. Welcome, Ebi.
Good morning, everyone. Good afternoon. Thank you very much, Franz, for the opportunity to share with the audience the experience we have in Guinea regarding specimen referral system. Next slide. So this is briefly the outline of the presentation that I'm going to share with you. Next slide. Next slide. As I'll give you a small background for those who don't know Guinea. Guinea is located in West Africa with 4 regions. And those who follow the news knows that in 2014, Guinea experienced a very big outbreak of Ebola. But following that, Guinea experienced also some additional outbreak of Ebola, Lassa, and Marburg in 2021 and 2022, mainly in the forest, mainly in the forest regions. Next slide. Like Kamiko just mentioned, specimen transport is a major challenge for the surveillance of priority pathogens. And to address those in Guinea, we conducted in February 2020 an assessment in collaboration with the Ministry of Health to assess the functionality and the cost of the existing system. And we have some findings, and I will just cite some of them. We observe a fragmented system, specimen referral system, lack of appropriate specimen packaging and materials, delay in transporting samples from the reference lab to the regional lab, from the peripheral to the reference and the regional labs, high specimen rejection rate, and a high transport cost. Next slide. So in order to address that, IDDS worked following the existing specimen referral system that is developed in the lab policy. The regional labs were identified in that policy as hubs, where all samples from the health district are shipped daily for testing. And when the regional lab does not have the capacity to perform the test requested, samples are sent to the reference lab twice a week on Tuesday and Thursdays. However, remote prefectures send directly their samples to the reference lab in Conakry without going through the hubs. So based on the existing SRS system, what IDDS considered the following in the design of the integrated system that we piloted. First, to have an integrated transport system that brings together all vertical programs and existing parallel transport systems in the country. Secondly, transport specimen and accompanied by a healthcare worker via public transport. Use of an electronic tool to monitor the temperature and to track the samples during the transport from the peripheral site to the regional or the reference labs. And finally, to conduct training of key actors, including lab technicians from the regional and district labs, drivers, surveillance focal point that we call here in Guinea, médecins chargés de la maladie from the prefectures. Next slide. So following that, we put in place the pilot. And in order to conduct the pilot, IDDS identified 3 regions where the pilot was conducted: Kindia, Mamu, and Farana, covering a total of 10 prefectural hospitals, 22 health centers, and 86 community health centers. IDDS also developed some training modules and trained about 50 healthcare workers, union drivers, lab technicians, prefectural focal point of animal health services. Next slide. So to move forward, IDDS signed a memorandum of understanding with the drivers union, who will be in charge of transporting the samples from the peripheral to the regions and the reference lab. Provided equipment made of mobile phone, call of internet data to the lab focal point who were all stationed at the hubs. And then we developed an application for the geolocalization and recording of temperature of the samples during transport. Next slide. So we conducted the pilot for a period of 3 months from December 2021 to March 2022. And during the pilot phase, with a total of 246 samples that could not be tested at the regional labs were transported to the reference lab with a rejection rate of 0.4%. So roughly sample transported included Lassa fever, hemorrhagic fever, suspect cases, polio samples, tuberculosis samples, some meningitis samples, etc. But here I would like to stress on the hemorrhagic suspect cases and the Lassa fever. Those samples, when we have some cases like that, samples were transported accompanied with a healthcare worker. So samples were not coming like the other diseases. Next slide. So what we found after the pilot phase is that the cost per sample transported went down from $58 to $13.8. And those $13.8 included all the recurrent costs, which was the monthly cost of transported specimen and the monthly communication costs that were given to the focal person. Next slide. So from December 2021 to October 2022, which is last month, we transported a total of 369 samples, and with a rejection rate of 1.808%. And based on the success of the pilot, there is an ongoing revision of the national specimen referral policy by MOH that want to incorporate the integrated specimen piloted by IDDS in the new policy. And we are collaborating with a partner, WHO, and the immunization program to roll out the transport of polio samples using IDDS integrating SRS model. And thank you for Kameko, who facilitated that collaboration. And we are also collaborating with FAO for transport of animal health priority pathogen using the IDDS integrated SRS system. Next slide. So what did we observe during that? One thing is that the turnaround time from sample collection to the delivery to the reference lab went down from 10 days to 24 hours. And samples were transported at the required temperature with a very low rejection rate and a reduced sample rejection rate from 15% to 1.08%. So the lesson learned and the takeaway that we had from this pilot that we conducted is that a joint planning, including all partners, Ministry of Health, and also integrating vertical programs were crucial to improve the specimen referral system in Guinea. And IDDS will continue to support the Ministry of Health and partners to roll out the SRS model that we piloted at the national level. Next slide. Thank you very much for your attention.
Thank you, Eddie, for sharing your experiences from Guinea with us. Now we will have our final speakers, Dr. Zien and Dr. Nguyen, who will take us through their presentation on specimen referral system in Vietnam. Go ahead, Nguyen. Nguyen, you might be on mute.
Yeah, hi everyone. So first, I will give some of the background on the specimen referral system activity in Vietnam. It's one of the major activity in IDDS GSS, and we'll have two major sector we currently work with. That is human health and animal health. And on the human health, we focus on the public health institution and laboratory, and not yet the curative sector. What we refer to is the hospital and clinical facility. And so we work primarily in three pilot provinces: one in the north, Thái Nguyên, one in the central region, Bình Định province, and one in the south, named Đồng Tháp province. And you can see on the map that each region we have at least one public health reference lab at regional or national level, and also one animal health reference lab, which is referred to as regional public health offices, or RAHO. Number 2 in the north, number 4 in the middle, central region, and RAHO 7 in the south. Next slide. So on this slide, it looks a little bit busy, but I just want to highlight some essential information here that about the existing referral activity is essentially ad hoc network, and there is no organized system for the most of the diseases, except for some vertical program such as TB or HIV. They have like a silo system. And essentially, for most infectious disease, the specimen is collected at the district or provincial level, and then they refer to provincial lab, public health lab, or animal health lab, and then it could be further transported to regional or national lab. Or for human health side, some testing can be done at the provincial center for disease control. So that is a little bit more advanced for the human health side compared to the animal health side. And you may want to know that in Vietnam, the transportation means are quite diverse and accessible, including agency car or public buses, including short range within the city or long range. We refer as coaches, and also private motorbike. Actually, private motorbike is very popular in Vietnam. Every family have say 2 or 3 motorbike, so it's very flexible in terms of transportation mean. However, each one have its own advantage and disadvantage in terms of the transporting of infectious specimen. For example, for agency car is quite like fast and good about control about safety or biosecurity, but it's high expenses. And for public bus, it's fast and convenient, but I mean convenient for pickup or delivery combined with some of the motorbike taxi, but also it also have some issue with biosafety and biosecurity. And of course, there are some courier company providing service. They can transport specimen. However, they often don't treat the specimen as a special service, but general good. Next slide. So our IDDS approach in Vietnam is quite the same as you heard before from Kamiko and Nisha's mentioning before, but it's quite like we start from beginning from technical group working establishment and all the way through like training people operate, monitor, and how we work to how to enhance sustainability, and we're looking for what to advocate for scaling up. Next slide. And here I just want to give some example of how we do some of the steps in the approach. First, about mapping of lab at the regional or national level. So we often we need to collect the GPS location or the type of test and the test capacity in terms of number that can be done in 1 day or in 1 week. And what about other information like receiving time, other requirement, and the turnaround time for that lab from the receipt delivery at the lab until they return the result and other information. Next slide. I want to say that often the lab are located in some of the central, like large city in northern, central, or southern part of the country. And here you can see some of the material and tool that we prepare or procure to provide to participating facility, including spill kits, PPE, and some of the other packaging material and cold box, thermometer, for example. Next slide. And about establishing a specialized courier service, we work with several companies to explore the opportunity because actually all of them do not provide the service publicly. Some of them provide a specialized service for like target company, like vaccine company, but essentially we need to work with some large network company, and then we select one of the private company that have a nationwide pickup and delivery network. We didn't choose. We could say we couldn't. We could not succeed in engaging some of the state-owned company because their system, their management is quite like wieldy and not flexible in terms of pickup time or delivery. So we finally found a private company with a large network, but also very willing to collaborate and provide the service that we need. And the service here we focus on timely need and biosafety, biosecurity, among other. Next slide. And another thing is that we require the time of the delivery, or the time in transit from the courier service is divided into different long or short distances within 6 hours or within 12 hours or 24-hour maximum, depending on the distance from the referring site to the lab that receive the test. And then also we make sure that the packaging is done properly by the staff of the referring agency, and also checked by the courier service staff. And of course, the temperature inside the packet is monitored, and it should be between 2 to 8 degrees in most cases. Next slide. Yeah, and here are just some picture of some kind of training. We essentially provide training on packaging, on transportation, and procedure for in handling of leakage or spillage incident, and other more in-depth training for health or animal health to monitor and evaluate the system. Next slide. And here are just some picture of the training material, including some video and the keychain card as a job aid to remind the people involved in the system about how to handle the leakage or breakage of specimen packages. Next slide. Yeah, so next, Dan will talk about some of the initial results we have so far. Dr. Zhang, please. Please turn on your mic.
Jiang, you might be on mute. We still can't hear you.
Maybe I can help Zhang with this too until he can fix the issue. So in the past 4 months, from June to October, we have transported or received and transport a total of 270 packages, and it's divided into different provinces, 3 provinces into human health and animal health, and you can see that the number of specimens most number are in Đông Tháp province, in Bình Định and Đông Tháp province, and not much from Thái Nguyên in the north. And I would like to say that all of these packages are transported and accepted by the referral lab, and no of the specimens are rejected. That's one of the good thing. However, there are also some like the general some issue with temperature monitoring. Some of the lab do not like monitor very closely, and they just record it like between 2 and 8 degrees Celsius. Next slide, please. Next slide. And in the last slide, I will want to highlight some of challenges and opportunity. What work about the system? We recorded that most refer packages are delivered by timely, between 80 and 90%, depending on the month. So the time recently is improving in the time that the package in transit. And for SOP for packaging, they are follow quite good, and other biosafety SOP also good. The service for human health and animal health are integrated, and that is a good thing that we can operate the system for both sector in One Health approach, and the communication between the all the people involving in the system are also effective. But there are still something to improve, including the pickup and delivery time. It need to be shortened for some urgent or special purpose that they want to have turnaround time of result within 1 day or within daytime, for example, for animal health, checking up of the for commercial purpose or some other purpose. And then the stronger monitoring of temperature need to be done, and also improve functionality of the data management system. And there are some opportunity for our future activity or continuing in fiscal year 23 is to how to implement or expand the pilot to curative sector, and also to advocate for integration of costs into social health insurance scheme. Thank you. That's Vietnam's. Thank you.
Thank you, Nguyen, for sharing your insights from Vietnam. We have now reached the final part of our program, and we will welcome questions from the participants. So if you have any questions, feel free to enter them into the chat window, and we will direct them to the group for a response.
Thank you, Franz. Sorry about the typo here on the slide, just some late night editing here, but for everyone, his name is Win Wen, and we have included his contact information as well, so if you wanted to reach out to him. Our first question is kind of broad for all the speakers, but I think I'll start with Kamiko. In your opinion, how does a country decide whether to kind of fully decentralize testing or to pour additional investments into actually improving the specimen referral system itself? Big question.
Yes, that's a great question, Nisha. Thank you. And it's a question that's relevant to many countries. So I mentioned diagnostic network optimization, and that type of exercise is actually great for answering those type of questions, because you can look at various scenarios. You can look at a scenario where the diagnostic system is more centralized, the network is more centralized, versus a decentralized network, also incorporating the specimen referral needs of both scenarios. And you can look at how that will impact the costs overall, looking at those two different scenarios. So diagnostic network optimization, which is an analysis that's conducted through computerized software, allows to do that type of pretty in-depth and complex analysis, and I think can be the best tool. So many countries now have gone through this and have looked at decentralization of various testing networks. Thank you.
Great. Thank you so much, Kamiko. We have a few questions coming in, but while I review those, I'll turn to Ebby next. So in Guinea, you spoke about kind of which couriers you were using across the system. Did you experience any hesitation from the drivers because they'd be, they're aware that they're transporting potentially infectious specimens? So how did they respond to that?
Thank you very much, Nisha. I don't think they were not hesitation because they are actually used to. Remember, I told you that specimen transport was done accompanied by healthcare worker, and most of them were using public transport. So they're carrying their cooler box, putting it in the vehicle, and transporting and carrying it to the reference lab. So they were kind of very excited actually when we went to them and included them in the training, because in the past they were just transporting. So involving them actively in the design and the implementation was a very good experience for us and also for them, and they are willing actually to continue working with us on this process. Thank you.
Thank you, Ebby. And perhaps you and Wynn can kind of answer the next question, since you both touched on this topic. But what did you perceive to be the main challenge with operating or overseeing this integrated specimen referral system approach? So when you spoke about animal health facilities and human health facilities, and then Ebby, you had spoken about multiple diseases and providing transport services across the board for those. So Wynn, first with you, what did you find were some of the challenges there?
Thank you for your question. I think the main challenge is that in Vietnam, the availability of so many options for transporting, like public buses and even motorized bike for shorter distance, and general courier service, they also accepted to transport. And so it's quite natural for the referring side to just send any random choice that they think is most convenient or fast to them, but they doesn't care so much about biosafety or biosecurity, or how to monitor the time or data on how well the transport is. So the key thing is how we advocate or how to train them about using a professional transporting service. And also for some facility, they still have the habit, or they prefer to bring the package themselves. It's okay, but sometimes it will be hard, or it will be like human resource issue, especially in times of epidemic, especially the COVID time. It's the public transporting is slowed down, and it's difficult to carry all the specimen to the lab. So that's a Vietnam experience. Thank you.
Thank you, Wynn. Ebby, any thoughts from your experience in Guinea?
Yes, in Guinea, the major challenge we had was the integration, because as I mentioned, we have fragmented system in place and vertical system. So bringing all of them together was the major challenge. And in the past, the system, like I said, was accompanied by a healthcare worker, and there was some finance implications, because when I transport a specimen and I come to the capital, I'm reimbursed by transport, I'm paid per diem, etc. So now the system that we have was cutting down this. So it was a bit challenging at the beginning, but gradually people kind of bought in, because they saw that it was more efficient. And samples turnaround time by 24 hours, it was reaching the reference lab. So gradually people bought in, and actually that's what helped us moving forward. Thank you.
Thanks, Ebby. And while you're on audio here, Seydou, our country team lead from Mali, asked, can you provide clarity on who are the stakeholders that were involved in that memorandum of understanding? You know, who signed on and who participated?
Yeah, that's a good question, because the memorandum of understanding, since we're still at the pilot phase, we signed it as IDDS. Of course, with the implication of the ministry, because when we develop the memorandum, they have to buy in, they have to give their input, because moving forward, they will be the one taking over. So we work with the lab services, we work with the National Public Health Lab, and we work with other stakeholders of ministry that were involved in. But to sign the contract, it was IDDS who signed it directly with them. But moving forward, the plan was really as we move for the ministry to take over. Thank you.
Thanks, Ebi. Kamiko, there's a question here for you. So what type of tools can be used to analyze the specimen referral system that's best adapted, or components of it that are best adapted to each country? You know, are there specific pieces of the system that need to be considered based on kind of inputs and resources available? How do we go about doing that in a cost-effective way?
So that would be a hard question to fully answer. There are various tools and resources that are available to look at different aspects of the system. So in general, if you want to understand more about what type of specimen referral systems exist in country, and how are those various systems working at all levels, the best thing to start out with, I would say, is a general landscape assessment. So this is what has been done in many countries by IDDS, and there are assessment tools to help get a good understanding, at least, of what exists. And that would be assessing all of the various components of specimen referral systems. So that's probably the best comprehensive tool to look at all of these systems as a whole. If you're looking to do more detailed analysis, and you can do a cost analysis on the various aspects of the various components, and do a cost analysis that will yield a cost per specimen transported, for example, as was shown in Ebi's presentation. So that type of analysis can be done if you specifically want to look at costs and look at how costs change over time. There are various other indicators that can be calculated to measure the 5 goals, the 4 other goals plus costs that I've mentioned. So there are tools available to help to understand what indicators might be most appropriate for those 5 goals, and then specifically how to calculate those. If you're looking at doing an overall network analysis, as I mentioned before, there are tools not only for network optimization, but there are also tools that focus more specifically on vehicles and transportation routes, and how to make those more efficient. And that, again, is using computerized software. So there are a lot of different tools and resources available, and some of those would be highlighted in the specimen referral toolkit that I mentioned. Thank you.
Perfect. Thank you, Kamiko. And thank you also to Win and Ebi and Jiang as well while he was here. That's all the time, unfortunately, that we have for the Q&A portion. So to conclude our webinar, I'll turn over to Rob Salerno, the IDDS Global Health Security Team Lead, to deliver some brief closing remarks before we adjourn. Rob?
Thank you so much, Nisha, and thank you so much to our speakers for a really engaging discussion. I was really struck by all of your presentations, and I think, we heard really well that, now more than ever, really, strengthened lab systems are really critical for early detection, especially when we are facing, numerous outbreak response opportunities. And I think what we've seen is IDDS and the SRS that we've developed supporting both Ebola, monkeypox, and plague. And at the same time, specimen referral is not just critical to the lab system, but also critical to strengthening the health system. And I was really struck by Ebby's presentation where we saw the actual per specimen cost be so much lower when we had a robust SRS system in country. And then lastly, I was really pleased to see how in the Vietnam example, we're actually able to work across sectors and really optimize a One Health approach. And I think that shows, how an SRS can be developed to have greater remit beyond the health sector and actually, leverage the investment across multiple sectors, truly taking a One Health approach. I want to thank our collaborators, our national stakeholders, and really USAID for supporting this work. It's really very important. And we're really grateful for the opportunity to be providing this type of SRS support across IDDS. So thanks to everyone for your participation and hard work. Thank you.